Hi, Kristen Calloway back. We are going to talk about complications in airway reconstruction for this talk. We'll go through just a few issues. So nobody likes to think about pneumothorax, but it's something we need to consider when we're taking a rib harvest. So if you experience a pneumothorax intraoperatively, this is someone who's going to fail a bubble test. So depending on how the patient is doing intraoperatively, you want to first talk with your anesthesia provider and manage it if you need to. But the way to repair it is to sew it up with a fluorochromic stitch. If you notice a pneumothorax postoperatively on a chest X-ray, then again, if it's small, you can try to manage it conservatively, but otherwise it needs to be managed with a chest tube. As far as suprastomal granuloma management, the management for these is, as I alluded to in the last talk, you want to apply a combination of an antimicrobial and a steroid drops to this, so in the nebulized form. So we like Ciprodex drops, but you could use Tobradex or whatever other combination that your hospital has. So when we do this, we administer it nebulized by the oral route twice a day for 7 days. The way we make a nebulization from that is 1 cc of Ciprodex mixed with 1 cc of normal saline and nebulized. And then as far as down the road, you want to take a look at the end of those 7 days to see if your granuloma is gone. If it is impeding a capping trial, for example, you could just try capping and see how they do. But then there's a subsequent role for endoscopic excision with cups if the nebulization doesn't work, and so on and so forth as far as surgical excision. Unfortunately, sometimes we do see posterior graft displacement, or any graft displacement rather, but this is an example of posterior graft displacement. So the big question is, what do you do when you see this? And you have to do something in order to optimize your outcomes, because that's going to occlude your airway. So there is a role for laser excision of these if you do have a laser available to you. Otherwise, unfortunately, you do need to go in and revise the surgery with a graft replacement and try to get that graft into place wherever it was supposed to be. As far as subcutaneous emphysema, if you experience an air leak postoperatively after your airway reconstruction, the best thing to do if it is progressing and if it is a problem is, so first of all, you do conservative management and you can observe it, and if it's not getting any worse, then you can just leave it alone and have your patient on antibiotics to try to prevent any infection. If it is getting worse, then you may need to bypass that anastomosis with a cuffed trach versus a cuffed endotracheal tube. So the whole idea here is to isolate the area of leaking and bypass it. So you have a cuff below the area that's leaking, and your endotracheal tube will bypass the anastomosis and go straight from your lungs out to the mouth. Or your trach would go from the lungs out to the outside world. So you leave that bypass in place for a number of days. It could be anywhere from like 3 to 5 to 7, depending on how things are going. And you want to monitor the degree of the crepitus that your patient's experiencing. If they're not already on antimicrobial coverage, we would recommend starting some. And then finally, if that option fails, you do need to go in and explore the wound and revise your anastomosis. For nasal alar necrosis, this is a dreaded complication. So if cartilage is exposed, you do need to place your patient on a fluoroquinolone antibiotic for cartilage penetration. Regardless, your patient does need to be on an antibiotic ointment to the area for about twice a day, and that can continue for as long as it takes to heal. Usually that's about 7 or 10 days. Finally, if down the road your patient has a cosmetic deformity from this, you do need to allow time for scarring and contracture to happen, and then you could consult with a plastic surgery colleague or evaluate the nasal ala for possible revision or cartilage grafting, whatever whatever the degree of the necrosis necessitates or calls for. We wouldn't do anything prior to 2 or 3 months, if not, even waiting 6 months would be reasonable to wait for all the scar contracture to help give you an idea of what your patient might need. Accidental extubations, this is why we have an airway plan in place. So, and this is why the sort of emergency planning is super critical. So you want to, if your patient's accidentally extubated, you need to implement your emergency airway plan, whatever that is. So if a trach is present, you have a stable airway, and you have time to take the patient back to the operating room for a reintubation, so that you can visualize your grafts and prevent them from being displaced with reintubation. However, if you do not have a trach in place, and you need to reintubate the patient right then because they're not breathing on their own, then you do need to perform careful but quick reintubation there. And unfortunately, often this is done by someone who is not the surgeon, but they do need to be very careful and educated as to where the grafts are placed, either in an anterior or posterior fashion, in order to avoid displacing them.